in practice, I find them often complementary. Liquid has the advantage that it integrates, or at least tries to integrate everything at multiple tumor sites. Sometimes that can also be a disadvantage. If tissue, you can learn about one specific site if that one specific site is your problem. But there is a whole literature, at least a diagnosis on the complementary nature of these, that there are some that they're overlapping Venn diagrams. There are some changes you're going to find only on liquid, some only on tissue in individual patients. And I want to comment on something that also overlaps with a question, if I can be forgiven for merging our sessions, but on the idea of putting these together, because they are complementary. They get different information. One is faster than the other is more sensitive. The companies are starting to address this. And again, reminding everyone, I have absolutely no incentive whatsoever to recommend one or the other. With that disclosure, I'm going to take license to comment on this. The companies are starting to get savvy about this. I happen to use Tempus at my institution, and they're starting to offer that if you order both, they'll guarantee that the patient doesn't get double billed, that they're going to view themselves as a single package. The unfortunate thing is that in my experience, they're not the fastest. Guardant seems to be the fastest. I've had answers within 3 days from them. So, if speed is what you're looking for, they may be the best, but there's going to be an evolution because there's competition between these companies, and they're going to be creative approaches, I think, to help us to best serve our patients with both technologies.
Yeah. Dr. Weiss, if I may, I think there's one context that we think about, perhaps that liquid biopsy may be inferior. And so you guys will learn kind of in multiple talks coming up about resistance to targeted therapies. And sometimes we learn that resistance can be very complicated, such that the cancer actually changes its entire shape and becomes a different type of cancer, like a small cell cancer or a squamous tumor. That type of change can be very aggressive and is not easily picked up with a liquid biopsy. And so that is part of the components and kind of proponents of a tissue biopsy. That's part of the reason that there's that tension in terms of completely replacing a tissue biopsy with a liquid biopsy.
Yeah, I completely agree with you. And I think that, like the message, for our progression on targeted therapy has to be absolutely clear. As you mentioned, there are histologic transformations, whether it's squamous or a small cell transformation, on an EGFR inhibitor. And so it's really critically important that if you're going to utilize that plasma first approach on patients who progress on targeted therapy, that if you don't detect a specific mechanism of resistance, that patient then subsequently undergo an invasive tissue biopsy. And then I want to bring back your kind of comment, Dr. Weiss, about the complementary nature of tissue and liquid biopsy. I think you're exactly right in that, now we have multiple different studies that have demonstrated that the combination of tissue and liquid biopsy, really does augment the number of patients who are identified to have actual mutations and are thus, candidates for targeted therapies. I think, things that need to be performed are kind of cost-effective analysis of that process, and ideally, they might be done in a sequential fashion, whereas the liquid biopsy could be potentially done first, and if that's negative, then you could run the tissue biopsy. And one of the reasons that that's kind of not done routinely currently, and that they're performed concurrently, is that when the turnaround time for tissue sequencing is actually, pretty long, and it can take a long time for you to figure out that you actually don't have sufficient tissue or that's going to fail on the sequencer. And if you wait, that long to determine, oh, well, I need a liquid biopsy or, a repeat tissue biopsy, you're delaying, an already prolonged process, for patients where both you and the patient, you really just want to get treatment started. And so I think for those reasons, there's been really, growing interest to use them concurrently, both to get an answer as soon as possible. And, as you mentioned, that, they're really complementary in nature, and that, to identify the most number of patients that might have an actual mutation.